Welcome to Chapter 24, Trauma Overview. In this chapter, it's going to be a broad overview of all trauma injuries, and we're really going to dissect mechanism of injury, or MOI, and to see how that relates to trauma injuries on the body and the different systems. So, generally speaking, traumatic injury occurs due to force applied to the body, too much force that the body's not able to either absorb that energy or disperse it without it causing structural damage. And as you'll see in a lot of the areas that are major serious injuries of concern, usually are places of the body that are well protected, like let's say the lungs and the heart being protected by the ribs, which is good, except when that structure, the rib cage, becomes compromised due to force applied to the body. That actually is the part that is most likely to damage, either have a rib broken and puncture a lung, causing a tension pneumothorax, or the same thing can be said when we think about spinal cord injuries. We may find a patient after a significant mechanism injury, maybe an automobile accident, where their vertebrae, their spine has been compromised. That's why we want to make sure that we do such a good assessment and actually palpate and understand if there's any suspected structural integrity problems with the spine, or if they have any neurological deficits, even something that might seem not as big of a deal as just some numbness or tingling in one extremity, because the concern is that that vertebrae may be compromised, may be broken, but hasn't damaged the spinal cord. And then if we, in trying to get them to that higher level of definitive care in transporting them, we don't take the appropriate precautions, spinal motion restriction or full C-spine, and they may move, and the vertebrae then could sever that spinal cord. So a lot of the structures in the human body that are there to protect vital organs, also when we think of trauma, when they become compromised, they're the ones that do the most damage. And then medical emergencies, we kind of gotten a handle on. It's illnesses that we're looking for, different body systems. And then obviously the takeaway to remember is you want to rule out a trauma injury if you think that you're on more of a medical call, and the same thing for a medical call. You want to rule out the potential for trauma. So always keep that in the back of your head. Now when we get on to index of suspicion, this is where mechanism of injury and understanding the story, understanding what happened to that patient, how much force was applied to the body and where, so that we can really look closely at those areas and suspect that there may be an underlying injury that we don't see. When we talk about trauma injuries, the concerning part for us pre-hospital, because we don't have x-ray vision out there yet, is the blunt trauma or the closed injury due to the internal bleeding and areas such as the cavity of the hip that can have significant blood loss before we even see any outward signs. So that's where we really try to get a good awareness of the story. We have an index of suspicion for where these injuries might be and how significant, and we help that guide us. So when we look at the patient on a trauma call, we're not just looking at the patient as if they were anybody else. We're looking at them through kind of the spectrum of their mechanism of injury. How much of force was applied to the body and where, so we can better understand what we're looking at. So energy and trauma. As we talked about before, when the body is exposed to energy levels beyond its tolerance, that's when we get a trauma injury. And, we're not protected like, beetles with these outside armor plates or anything like this. So a lot of activities that we partake in, driving around in a motor vehicle at 65 miles per hour. This is when we come to a sudden stop, our bodies just weren't designed to absorb that that energy. So that is when we have a trauma injury. Mechanism of injury, again, how much of force was applied to the body and where. Mechanism of injury is huge. If you don't understand the mechanism of injury, you're not going to be able to appropriately assess and understand the potential for having that index of suspicion that they look maybe that they're in shock, or they may have some internal bleeding of some kind, or you may not get them to the appropriate definitive care, meaning you take them to a critical access hospital like Banner when where they really need to go is a level 2 trauma center such as Renown. So the mechanism of injury can make things kind of a simple call. It's not our job. We don't fail if we upgrade somebody and fly them to the level 2 trauma center based off their mechanism of injury, and the fact that you have an index of suspicion for injuries that might be there, right? We try to base that also off of the signs and symptoms that we see. But ultimately, this is going to be, like I said, the way that we look at our patient and the way we understand that information that we're getting in our assessment is all going to be through that the eye of the mechanism of injury. Three concepts of energy. We have potential energy. So this would, when we think of this, oftentimes we think of a fall. That's why the three things we want to know with a fall: how far did they fall from? Because that's their potential energy, right? How far up were they? Were they at the third story, over 30 feet up in the air? That's going to have a much more significant potential for having a traumatic injury than if they were a ground level mechanical fall, right? So it's really important that we understand that potential energy when we're looking at their mechanism of injury. And then kinetic energy, that's the energy while it's at work, right? So if we think of that, think of the energy of a bullet as it's cruising by, right? The bullet has energy as it's moving, and its energy is based off of half of its mass times its velocity squared, which we'll go over in a second. And then energy of work is just the concept of, if you can think of, you're in a motor vehicle traveling 65 miles an hour. Once that vehicle becomes to a rapid stop, hits a tree, then that energy that it has, it's going to roll into something else, right? It's going to roll into the documents that are in the vehicle. It's going to be absorbed elsewhere. So that energy transfers at that point. It doesn't just disappear, right? Energy it's not become created or destroyed. It's just changing forms. So these concepts kind of give us help us understand, give us a backbone when we're looking at mechanism of injury, because it's all about that energy. Those forces, how they're applied to the body and where, will give us a better understanding of what's going on with our patient. Forces that bend, pull, compress tissue beyond their inherent limits result in an injury. A different mechanism may produce many types of injuries. We usually break these up into non-significant or significant. I like to think of these as isolated or multi-systems. So non-significant injury is going to be that isolated body part. This is the patient that stepped off the curb and felt a pop in their ankle. They did not have a loss of consciousness. They remember the full event. When you ask them what is bothering them, just their ankle. And versus the significant injury or the multi-systems injury to more than one body system or more than one area on the body. If you think of a patient that falls off of a ladder and they may be complaining of just pain in their wrist, they may have an angulated wrist, they fell off the ladder, they try to catch themselves with their wrist, and their wrist gave way, caused an injury there. Their back or head hit the ground as well, and then you also see some evidence of some trauma to their left shoulder. In my opinion, this is a multi-systems trauma because the force that was applied to the wrist, though they may have absorbed some of that energy as they caught themselves with the wrist, but the energy that it caused that wrist to give way, some of that energy was also applied everywhere in between where you see those signs of injury. So you see it on the right wrist and you see it on the left shoulder. What's in between there? The spine, the head, all those things. And they may be more worried about their wrist because it's angulated, it causes more pain, it's a distracting injury. But we got to not lose sight of this is multi-systems. We have to evaluate very well, do due diligence to really rule out the potential for a spinal injury by doing a thorough head-to-toe assessment and checking all of their systems and palpating and seeing for any obvious deformity, any pain on palpation. This will so when we're looking at a trauma injury, whether it is an isolated or multi-systems trauma, we're generally going to be doing the same scene size up, primary assessment, looking for the immediate life threats and fixing and mitigating those as we move on. It may change your history taking slightly, but when we really notice the changes when we go over that secondary assessment. An isolated injury, again, remember, no loss of consciousness. You essentially have had some time with asking the patient's questions, so you're trusting what they say. That they don't have anything that could, dementia or under the influence of drugs or alcohol or any organic psychological issues. That you're trusting what they're telling you. Then you can kind of really focus on that isolated injury. You can take care of it, get them onto that next step of care. But for a multi-systems trauma, we need to remember to be doing a thorough head-to-toe assessment so that we're able to rule out or rule in potential for other injuries, other spots, right? This is, again, having that index of suspicion. So they also have on here falls from over 20 feet, taken in consideration. One story is about 10 feet, and then pediatrics, just because of their size, it's going to be much, much less. Single story or 2 to 3 times the height of the child. And remember, another problem with pediatrics, with kids, just because of the proportional size of them, they are kind of like lawn darts where their head is going to hit the ground generally first, right? So this is another reason why these would be considered significant injuries, with these falls from any height that their body would have enough time as it's falling to rotate and potentially hit their head. Other mechanisms of injury that we consider to be significant are these high-risk auto accidents. If there's extrication time greater than 20 minutes, and it's kind of under the idea of if it takes that long to get them out, how much force was applied to the vehicle to manipulate that metal, pretty significant. But you may also come into this, especially logistically, just time to get somebody out of the vehicle. Just because they don't have personnel, or maybe they're not as used to utilizing their extrication equipment. Ejection, partial or complete. The really dangerous one there would be a partial ejection, right? So they weren't secured in their seat during a motor vehicle accident, but they only came part of the way out. So especially if this vehicle was to roll or rotate, then whatever part was sticking outside of the vehicle, you can have a high index of suspicion that there's going to be significant damage to that extremity or body part. Death in the same passenger compartment is going to automatically up your, when you look at the patient that you have that may not have any complaint, what that does is tell us, hey, there was somebody else in this vehicle that had the same amount of force applied to their body, and it was enough to kill that patient. Now, there may be other factors involved, comorbidities of the other patient. Age is generally a big one when we think of trauma, especially with automobile accidents, because you have that coup contra coup effect as a vehicle or a person comes to a rapid stop, and then the brain slides forward, slides backwards, and can even slide forwards again as it's kind of coming to a rest and distributing that energy out. And its ability to move inside of the skull is going to cause for more potential damage to the brain. And just part of aging, your brain actually atrophies and becomes smaller, so it's able to move more inside that brain and potentially cause more damage. But always remember, if there was a death of a passenger within the same compartment, to pass that information along and have a high index of suspicion for internal injuries on the patient that may seem okay that you're talking to. A rollover without a seatbelt is obviously a high-risk auto accident. Intrusion of more than 12 inches in the occupant site, so that would be essentially if we're looking at the dashboard coming forward, or the doors going inward, or the roof coming inward, anything inside that space where the passengers occupy, or 18 inches anywhere. So if just the front end of the vehicle has been, we see it come in 18 inches, been deformed inward, we're still going to have that same high index of suspicion and presume that this is a high risk auto accident mechanism of injury, because of the amount of damage. Cars are designed to crumple, but that's some significant intrusion on the front end. So the amount of force that was dispersed is going to be quite significant that the patient is experiencing. And then the autoverse pedestrian or bicycle, if they're thrown over, or if they get hit with significant impact at over 20 miles per hour, again, we should have this high index of suspicion. Blunt trauma and penetrating trauma. Blunt trauma is the result of force to the body that causes injury without penetrating soft tissue. Now, penetrating trauma is just trauma that causes a penetration through the soft tissue. Now, it's not more complicated than that. It's that simple. If a object has pierced through or penetrated the soft tissue or the body, then that's penetrating trauma. If the skin is intact, or if it didn't penetrate through the skin, I mean, you may see some still deformity, discoloration, bruising, obviously, but that's all internal. And the problem with blunt trauma and penetrating trauma is blunt trauma is a lot less obvious, right? And even when we look at blunt trauma, some of the pictures that we'll show, you'll see it after the fact, so that there's some bruising or something there, but that may take a while to see. One that often we see, if people are wearing their safety equipment appropriately in a motor vehicle, we'll see that seatbelt bruising across their chest. Also, another way to kind of be hard to say that you weren't the driver or the passenger, depending on which direction you have that lap belt come across when the bruise develops. But this isn't something that happens immediately. Oftentimes, you'll ask a patient if they have any pain. They'll describe some pain in their chest, and then as you're with that patient, that bruising can develop. Now, penetrating trauma is going to be a lot more obvious, right? We see actual hole penetration through the skin. Blunt trauma. Again, result object making contact with the body but not penetrating the skin, but we still had that transfer of energy. So you swing a baseball bat as hard as you can at somebody and hit them in the chest. All that energy from the swing, once the bat makes contact with that chest, it starts to transfer to the chest itself. Motor vehicle crashes and falls are the most common mechanism of injury for blunt force trauma. Be alert for skin discoloration, pain. That's why we need to do that thorough head to toe assessment, right? This is what we're really doing it for. We're looking for these, the potential for blunt trauma, internal injuries, and maintain a high index suspicion for hidden injuries. And as we go through here, we'll try to talk about, things that are more concerning, right? If we had somebody that was in a motor vehicle accident and they weren't wearing their seatbelt and their head made contact with the windshield. We see a damage pattern on the windshield, maybe some spidering of the windshield, and it's scalped part of the patient, the top of their head. It disfigured the top of their head. And then as we look at that patient, we see that they have one pupil that maybe is fixed and dilated or not reacting appropriately. They have unequal pupils. More concerning than the disfigurement of the scalp and the fillet of that, even it might be bleeding, having some capillary bleeding going on quite a bit. But the more concerning part is that blunt trauma that they sustained, and what you can't see. So I would be concerned of that patient, but it's not because of those scalp lacerations. And most people would look at them and, oh, that looks horrible, right? We need to jump right on this. But you, after understanding mechanism of injury and definitely blunt trauma, you'll think, yeah, I'm very concerned because I'm concerned about the force that was applied to that brain, and I can't see what's going on, but I do have evidence that there is a traumatic brain injury there with the unequal pupils. This is going to be that second collision, the passenger against the interior of the vehicle. We should be expecting extremity fractures, a flail chest, and maybe something less obvious like that head trauma. So don't be distracted by the other injuries when most concerning may be the actual head trauma or head injury that they have. Now, the third collision, passenger internal organs against that solid structure of the body, they're not going to be as obvious, and they're often the most life-threatening. And this is the big concern, and why we need to have that high index of suspicion is because the ones that are less obvious, those as an external injury, the internal injuries may be most life-threatening. And you can see on this patient, the contact is not just of the front portion of the brain, but also the back. As we get that coup contre coup movement of that brain inside the cranial vault, we see the spidering of the windshields there. That looks like where their head has been struck. Now, could that have been an object inside the vehicle or outside the vehicle that caused damage to the windshield? Yes. But remember, in our line of work, we have to have a high index of suspicion. And so we are going to be looking at these things to be suspecting, right? Now you're going to match it up with signs and symptoms. You know, if a patient did have head trauma, we would be looking at the eyes. They're the window to the brain. Are the pupils, are they reacting appropriately? Are they the same size? Are they both equal? We're going to be looking at that level of responsiveness. All things combined with that mechanism of injury will help us determine where our patient is at, how significant, and ultimately get them to the right location as soon as possible. With trauma, you know, diesel is going to be the treatment of choice oftentimes, and we kind of jokingly say that is because we need to get them to that definitive care quickly. So there are things that we can do to stabilize them, and oftentimes we may need to, like putting them in C-spine and getting them off scene, but we're really limit the interventions that we do on scene. We want to get a good story of what happened, understand that, secure the patient as best we can for transport, determine where the best place for transport is, consider things like a air ambulance, if we're especially in our local area, to get them to that definitive care, that trauma center as quickly as possible, because oftentimes these are corrected not by medications but by surgery, by a trauma surgeon. Let's talk about the different types of crashes. We'll start with the frontal crash. In all crashes, we're going to evaluate supplemental restraint system. This will be the airbag and the seat belts that are there to help with that secondary collision. Was the patient wearing a seat belt? Did the airbags deploy? Now, the airbags deployment, it may have not deployed when it should have, but oftentimes that can tell us about at least a little bit about the force that was applied to that vehicle if it engaged letting off those airbags. Other things to realize too, not unlike the body, how the things that are designed to protect us and protect our vital organs, the same thing with these supplemental restraint systems. They can potentially cause more damage just off of them working appropriately. And this could be the seatbelt. As the patient moves forward, it's good that it secures the body in that position so that they don't fully collide with the interior of the vehicle. But also, where that point of contact is made on that seatbelt, what does that go across? Often right across their chest, and so their lungs are right where their lungs are sitting, and maybe if they're wearing it inappropriately, and this is why it's so bad for people to, especially kids, if the lap belt isn't comfortable and they slide their arm through it, and then now it's right over where their over their stomach, where all their vital organs are right there. That's where it's causing injury and pressure. And then the airbags deployment, you can ask, especially if patients coughing or having some respiratory issues. It may be just from the dry chemical that expelled the airbag, helped it deploy, may cause issue there. But oftentimes when we think about the seatbelts and the airbags, it's to get a better idea of this force that was applied to the body and where, and so that we can have that appropriate index of suspicion. But despite airbags, we need to suspect extremities and those internal organs, because we can't stop that third collision, right? So those organs are still going to be essentially colliding with inside of our body. Here's a good example of that seatbelt bruising that we're talking about. So if we're looking at this patient here and how the seatbelt crosses his chest, for a bonus question, was he a passenger or a driver, or essentially what side of the vehicle was he on? So yeah, this would be a passenger, at least a patient. Would be a passenger, someone sitting on that passenger side. Another thing to remember with supplemental restraint systems is that they can cause harm when they're not deployed. So if you're working in a motor vehicle accident, remember scene safety, your safety number one, and just be aware of your positioning. If the airbag hasn't deployed on that front end, it may as they're extricating the patient. So be careful not to be in a position or be cognizant of where you're located if you're between where that non-deployed airbag is and the patient. Rear end crashes, known to cause whiplash type of injury. As the body is propelled forward, the head and neck are left behind. This has caused major problem to the cervical spine, and we should have a high index of suspicion that they need to potentially be in at least spinal motion restriction, if not full C-spine. Do a very good evaluation of that, the head, neck, palpation, look for any deficits, and also remember we talked about, be cognizant of the fact that if they're altered at all or if they have any distracting injuries, that we should be, because this mechanism of injury is so prone to have this type of head and neck injury that we need to suspect it and treat for it, even if the patient's not, right? Even if they're not outwardly complaining of it, because there could be other potentially distracting injuries, or they may be altered. If substantial intrusion into the passenger compartment, lateral chest, abdomen injuries on the side of the impact, possible fractures of lower extremities, pelvis, and ribs, organ damage from that third collision that we talked about. So T-bone's very dangerous. Have a high index of suspicion for internal injuries. Rollover and rotational crashes. A rollover crash is more prone to high profile vehicles such as large trucks, SUVs, but cars are able to roll over, especially at a significant speed. The injury depends on whether the passenger was restrained or not. We're really concerned about ejection or partial ejection. And the rotational crashes, spins are conceptually similar to rollovers. Opportunities for the vehicle to strike other objects, so there could be a multitude of injuries, and the damage pattern can be kind of hard to predict, but it should give you the index of suspicion that they could have potential injuries everywhere. So we've got to really do a very good, thorough secondary assessment. Car versus pedestrians. Injuries are often graphic and apparent. Can also be unseen injuries, that blunt trauma that we're concerned about. Determine the vehicle's speed and whether the patient was thrown into the air. If they were thrown into the air, remember that's also going to be multiple injury locations that they have, where they were struck, and also again where they landed once they finally hit the ground again. Evaluate the vehicle that is struck, the patient for structural damage. Now we talk about determining the vehicle's speed. This can be difficult to do, especially in a good kind of resource. Oftentimes you're going to have a police officer, highway patrolman on scene. An appropriate question might be, just asking them a quick estimation of speed. If not, we can kind of go off of the the posted speed limit, but also take into consideration oftentimes people do exceed that speed, especially on 395 going to Reno. Once you understand the mechanism of injury and kinetic energy, half the mass times velocity squared, we realize there's a big difference between coming to a rapid deceleration at 65 miles per hour and 85 miles per hour. Right? Because especially when you can't stop that third collision, and this is another reason why we have these speed limits in place. Car versus bicycle. Evaluate like a car versus pedestrian collision. We want to know whether they were thrown, and we want to understand the fall after they made contact, how they were hit. Inspect the helmet for damage. We want to take that with us. Things like this may not change a whole lot. The ER doctors, how essentially they're going to treat the patient and what they're going to do for them. But that information does keep going and follow up the chain, and it may affect the neurologist's determination when they go in to do that definitive care. Spinal stabilization must be initiated and maintained. Remember, at first, just like when we talked about keeping an airway open before you go having your partner rifle through and get that OPA out, the first thing that you can do is you can just manually open up that airway. So same thing with here when we talk about spinal immobilization and stabilization. First thing would be to get a resource, get a person there to maintain that head in line, right? To try to get that head into a neutral position. If you don't meet resistance or cause a lot of pain, then once you have it in that neutral position, they're married to that head, they're married in that location, and they're keeping that stabilization throughout the whole process until the patient is on a backboard, totally strapped down, head blocks in place, and their head strapped down to the backboard. Car versus motorcycle. Protection is mainly from the helmet and the leather or what abrasion resistant clothing that the driver of the motorcycle is wearing. When assessing the scene, look for deformity of the motorcycle, side of the most damage, distance of skid in the road, extent and location of deformity in the helmet. These are all going to be damage patterns that will give us an idea of where we should see these injury patterns. Now, this kind of also brings me up to a point when you come across a patient that was involved in a motorcycle versus car or any motorcycle accident, you can pretty much suspect it's going to be a multi-systems trauma. And part of the deal with a multi-systems trauma, in order to be able to appropriate evaluate, because you cannot evaluate what you cannot see, we need to strip the clothing, right? We need to cut those leather chaps off, cut those boots off if we need to. Now, oftentimes the patient may be hesitant against this because they like their boots, they like essentially their jacket, and so it's one of those, you're going to do what you do and then kind of apologize for it. We need to do our job. It's a big difference of saying, can I cut off your boots so that I can evaluate you, to once you already put a cut in them, they're essentially, it won't matter at that point. You've already cut the right, so they'll be less hesitant to fight you on cutting the left one. But we do need to visualize, right? Don't be bringing these patients or to the hospital or the next level of care that's been in a multi-systems trauma fully clothed, because how did you do a true secondary assessment on them? Car versus motorcycle. Then we'll talk about the head-on crash. Now, all these have different crashes, like we're talking about the frontal impact, side impact, rollovers for an automobile. Motorcycles have different, due to these different mechanisms of injury, different damage patterns. Now, as I read through these, it seems very straightforward and easy, and it is in a way, as you're kind of rolling it through. Okay, I can imagine what that looks like with a head-on crash of a motorcycle, right? The motorcycle is not paying attention, and they come up to a stoplight where a car is parked, and they hit that car, and then it stops the motorcycle, and the patient gets thrown over the end of the motorcycle and collides with the vehicle or on the ground or somewhere else, right? But realize we come after the fact. It's very unlikely, unless you're in your ambulance and you happen to see an accident happen right then, we're coming after it, and they may not even be near the vehicle, near their motorcycle. They're in a different position. Somebody's with them. They may be up even walking around, hopefully not, but they could be. And then that's why we need to respect the mechanism, have a high index of suspicion, and kind of play that video in our head. Okay, what happened? And then once you got an understanding of what happened, you can visualize the potential for injury based off of that a force applied to the body, how it was applied, and what happened to the patient. And then you can make a better determination of how you're going to assess to look for further injuries, and also how you're going to treat that patient. Angular crashes, a motorcycle strikes an object and the ankle, so the rider sustains direct crushing injuries to the lower extremity. So, that's when we're thinking about those femur fractures, and the problem, especially if it's not an open fracture or something that we can visually see, they can lose a significant amount of blood in that cavity before we even see any bruising, right? So again, we have that high index of suspicion based off the mechanism of injury. Ejection. A rider will travel at high speed until stopped by a stationary object, another vehicle, or road drag. Severe abrasions can occur. And again, this is where we need to remove the clothing, the protective clothing, and see where the extent of the injuries are and the locations for them. Another one where you may suspect a lot of abrasions would be that controlled crash. This is that technique that the rider will separate themselves from the motorcycle, and so it's kind of a controlled crash, but they still are the speed that they're going at, that speed needs to get displaced, and it's going to carry that patient and move them across the pavement, and as that absorbs the energy, it's going to also cause damage to the tissue, so be aware of that. Falls. Injury potential depends on the height from which they fell. And we talked about before, more than 20 feet, considered significant. Not to say that you can't have a significant fall from less than 20 feet. Good point out for how our history taking and important questions that can elevate something to be considered significant. One would be blood thinning medication. Right? If a patient's on blood thinning medication, even a ground level mechanical fall, which is kind of the medical terminology way to specifically and very quickly say that somebody was just standing on their feet and tripped and fell. If they hit their head and they're on blood thinning medications, this could be of significance, right? So blood thinning medication, oftentimes people will take it if they have atrial fibrillation to prevent the possibility of stroke, which we've talked about in previous lectures. So even if they don't know if they're on a blood thinning medication, if you hear that they have an irregular heartbeat or they have AFib, then you should have that suspicion that they are and treat them as if they are on a blood thinning medication until proven otherwise. Other common blood thinning medications, Plavix, Coumadin, you can ask about. Most of the time, people will know because their doctors have really ingrained it into them, the importance to notify somebody if that they're on a blood thinning medication. Sometimes people will consider aspirin as a blood thinning medication for our determination. Often we'll pass that information along, but that's a different concern. It's not a blood thinning medication as far as it stops the clotting process in a different way. Internal injuries are going to pose the greatest threat. So before you dive right in and go to splint that guy's right wrist, who we talked about fell from the ladder before, understanding what's going on, doing that thorough secondary assessment, and potentially understanding his eyes, his pupils are unequal, and then understand we're working with a traumatic brain injury here. That is more, his chief complaint might be right wrist pain, but what is more concerning to you is the fact that he has a traumatic brain injury. Patients who land on their feet may have less severe internal injuries. Their legs may absorb much of their energy of the fall. And this is kind of when you see those parkour people jump off of a very high height, is they kind of once their feet hit the ground, they roll out of it and they get up and they start running again because they're absorbing that energy, right? But I don't know about you, but if I was falling from 20 feet, I wouldn't think to parkour and roll out of it. So I would probably have my legs lock out, and if they lock out, then you can think of that. The force being applied to the feet, ankles, to the bones, kneecaps, and go all the way up to the hips. So they may have significant injuries all the way through that through the structure there. So we need to have a high index of suspicion and do a very good secondary assessment, palpation, and find out the potential extent. Take the following factors into account: height of the fall, type of surface struck, part of the body that was hit first. Those are the three things that we're going to want to know. You should have those right at the top of your tongue as soon as you're passing on a report, or if when you're documenting this. Very important to have that understanding, because it should change how you're going to assess the patient. Penetrating trauma may be caused accidentally by impalement, may be caused intentionally by a weapon. The thing that we need to, when an object is impaled into somebody, we are not going to remove that object. Now, the reason we don't remove the object is because that could be pressing against an artery and another hard structure, a bone or something, and kind of tapenade or placing pressure and preventing that from bleeding. And if you could imagine this knife that's in there, just based off the handle, I'm sure that there's a pretty significant blade underneath there. And so you don't know where along that blade, it could be at the point end of it, that it's actually blocking off that significant bleeding that's happening. And then if you remove that object and start to get that internal bleeding, it's going to be very difficult to stop that bleeding. So we're going to leave it in place. For this patient, it may be appropriate just take 2 head blocks and put it on either side of that and stabilize it. Anything that you can use that's going to stabilize that object for transport. And again, just like when we do a splinting, it's not about, we're not trying to stabilize that so that they can, essentially keep it in there for months from now. They just got to get them to the next level of care, get them to that hospital, because as soon as you get there, they're going to remove that. So we want it to be stabilized and secured, but don't waste time, on your wrap job. You don't get bonus points for that. It just needs to be kind of like a knot, something that holds tight, but is easy to tie and easy to untie is the methodology when we're stabilizing an object, or even when we're thinking about splinting an object. Now, the time that we're going to remove objects that are impaled is if they interfere with CPR. Right, so if that object you were unable to do adequate CPR due to the positioning of where it's at in the chest, then you could remove that object and then do your CPR at that point. With low energy penetrations, it's going to be like a knife being stabbed at somebody. Even though they're throwing out all that they got into it, that's still considered low energy in the scheme of things when we think of kinetic energy, right? It's not like a bullet. As the body moves through the tissue, it's going to cut the tissue, and then if the assailant deliberately moves that around, that distal tip could cause more damage inside of there. And you also got to remember the previous slide that we saw, the assailant was nice enough to leave their knife in there, but oftentimes you may not see the knife. So we need to get a good idea of how did anybody see the knife? How large was it? What kind of knife? Again, so that we can understand kind of what we're dealing with. But again, don't delay transport in order to find out this information. And when we work on our assessments, that's really what we kind of practice on, those, so we can get big picture. You can delegate things out, right? Getting blood pressures, getting set of vitals, getting them, C-spine, things like that if necessary, as you go and evaluate the vehicle or get the story on what's going on people that aren't going to be transported with the patient that may have vital information for you to better understand the mechanism of injury. Or, if you're working well with your partner, or firefighters are really good at this because they train on vehicle extrication. Have them look at the vehicle, describe it to you so that you can limit your time on scene. In penetrating trauma, the path of the projectile may not always be as easy to predict. One example would be a bullet. It may ricochet within the body before it exits. I know I've heard a tale of 22 being shot in the head may have enough force to enter into that cranial vault, into the skull, but not enough force to exit, and so it'll bounce around and kind of make mincemeat of the brain inside of there. The path of the projectile takes is its trajectory, the path that it takes, and then fragmentation will also increase the damage as that bullet comes apart, and it flattens or widens out, and it will cause more damage. Can also depend on the type of bullet fired, not just the gun that fired it. Relationship between distance and severity of injury varies depending on the weapon a lot. Drag slows the projectile. Area damaged by projectiles is typically larger than the diameter of the projectile. That's that cavitation that we were talking about. Energy available for a bullet to cause damage is more a function of its speed than its mass. Goes back to kinetic energy, right? When we look at that relationship of kinetic energy of mass and velocity, what did we talk about before? What is going to make more kinetic energy? The bigger mass or the higher velocity? So, more importantly than the size of the bullet is how fast or the velocity of the bullet as it was entering the patient. Next, we're on to blast injuries. And if nothing else, National Registry does like to ask questions about blast injuries. We'll talk about a common one that I see coming up here, but we'll just start off. The primary is going to be due entirely to the blast. So as that percussion, that wave, kind of like cavitation of a bullet, as that blast first is detonated, it's going to send a pressure wave that's invisible, that we can't see through the air, that may be even ahead of any objects, if it's a dirty bomb, anything that's inside of that bomb. And so what that has the potential to do is any hollow organs can essentially rupture with that as that pressure wave crosses through with that pressure gradient change, and also it will gravely affect someone's ability to hear because of our hearing canal and how the structure is formed. So the blast injury, the primary blast, what that should be telling us, people close by are not going to be able to hear. And unlike somebody that doesn't have is deaf and never has the ability to hear, or has maybe some degenerative hearing loss and is able to compensate, these are people that are not prepared for it in an emergency. So that can really throw us off on our assessments. If you could think about being at ground zero, or just a spectator during the Boston City Marathon bombing, and then now you have all these people, all these patients around, and then how do you assess them when they can't hear what you're telling them? So we have to understand that going in, right? Part of kind of being empathetic, realize what they're going through, so that we can better get information, get them where they need to go. Now the secondary blast injury is due to missiles being propelled by the force of the blast. So we talked about the initial blast injury being those that pressure wave coming through. Now it's all the tiny particles from the bomb, or maybe little pieces of objects that were around it but are small, so they're moving out quickly as the blast occurs. That debris. And the damage to the patient is being struck by the flying debris. And so a small object, high velocity, is going to cause penetrating injuries, right? So we have the primary blast is going to have that the shock wave as it goes through. Secondary blast is going to be penetrating trauma from debris, whether it be in the bomb itself or that the blast has caused. And then the tertiary, the victim is going to be hurled by the force of the explosion. So now they're flying debris themselves, and the problem that portion of the blast can cause is going to be once they strike an object, they're going to get some blunt force trauma. And then lastly, we have the quaternary, the miscellaneous blast injury. This could be burns from gases or fire that started because of the blast, whether the bomb had some other agent inside of it to cause more destruction. You could have some respiratory injury from inhaling toxic gases, or crush injuries from buildings collapsed secondary to the explosion. So these are all underneath the quaternary or miscellaneous blast injuries. Most patients will have some or combination of all four types of injury. And so the one that I kind of see that comes out a lot is what portion of the blast is going to cause blunt force trauma, right? And I think a lot of people in their head, they think the secondary portion, an object getting hurled through the air and striking the patient, but those are going to be more penetrating. Smaller objects, high velocity. The blunt trauma is usually going to be the patient hurled against an object. So just be cognizant of these different types of injuries. Really take away and visualize, if you were on scene of a call like this, the chaos that's kind of happening, and how we would mitigate that. Understanding the patients could not be able to hear what you're telling them, and how you're going to assess that type of patient. As always, be prepared, unfortunately, for a secondary explosion or a secondary device set off to try to harm you or people that are there to try to help out in this instance. Organs that contain air are more susceptible to pressure changes. That middle ear, that's talking about how they could become deaf. The lungs, so they may have some difficulty breathing because of that pressure differential. And then the gastrointestinal tract, a long, hollow organ that is subject to those pressure changes. Pulmonary blast injuries are going to result from short-range exposure to that detonation of explosives. So the closer somebody is to that object, the more that they may be subjected to that type of injury. Arterial air embolism can produce disturbance in vision, changes in their behavior, level of consciousness because they're not getting perfused the right way, and a variety of other neurological signs. So we talk about this with the patient that's pacing back and forth on the side of the highway after a motor vehicle accident. They may be the most injured patient out of anybody just because they're kind of in a state of shock, and not shock medically how we're thinking. Now go back to before EMT when you would think of shock, they're just not right in the head. This can also happen with these type of blast injuries. So as you're triaging, looking through, you need to make sure that you're checking on these type of patients as well. Solid organs are relatively protected from shock wave, but they may be injured from that secondary missile, that penetrating object, as it gets lodged in the patient. Neurologic injuries and head trauma are the most common cause of death due to blast injuries. Traumatic amputations are also common. And one thing that we did get out of the Boston Marathon bombing is the use of tourniquets that we've talked about. But want to bring it up here with a traumatic amputation. It would, if you're dealing, it wouldn't be an instance with multiple patients because you would want to save your tourniquets for a patient that needs it to obviously prevent blood loss. But if you're talking about one patient with an amputation, it may be appropriate to apply tourniquet as distal, just proximal to that amputated part. Multi-systems trauma involves more than one body system. Head and spinal trauma, chest and abdomen trauma, chest and multiple extremity trauma. So took a little bit for me to kind of incorporate this in my practice and really respect it until I, almost got burned, with a patient. When I say burned, something was developing that I did not respect. I didn't have a high enough index of suspicion originally, so learn from my mistakes. A patient that had fallen off a ladder. They caught themselves with their hand, complaining of wrist pain. No complaint of head, neck, or back pain. And then and I did not put this patient in full C-spine. And then when I was transporting the patient, they started asking me repetitive questioning, right? And so at that point in time, I applied a C-collar and had them not move their neck for some spinal motion restriction, but I did not respect initially that they were a multi-systems trauma, and I should have. When I did the secondary, they had wrist pain, and then he also had an abrasion on his shoulder. And now I realize, hey, that is multi-systems trauma, and everything in between there, including his head, and spine are in the path, and I have to have a high index of suspicion that they could have an injury there. So multi-systems trauma, it could even be just a little, when you do your secondary and they have some abrasions on their left side of their body, but they're really complaining of this broken femur on their right. Don't downplay that, right? That's a multi-systems trauma. It's not isolated. Well, that's just a couple scratches over there on the left side, and it's more, essentially their major injury, their chief complaint is pain in their right thigh. Well, that's the time that we need to even more so do a quality secondary assessment and suspect these other ones, right? Because what may be more life-threatening to the patient isn't the femur fracture, but potentially the brain or spinal cord injury. Golden principles of pre-hospital trauma care. Your main priority is your safety first, right? We need to make sure that we are able to conduct our job safely so that we don't become part of the problem. We need to make sure that our crew is safe and the safety of the patient. So this may take, it seems obvious, but sometimes when you think of a situation, it may not become, so black and white. And how would you go across that? One might be if you're at a motor vehicle accident and you need to, you're trying to make access to the patient, but you don't have the appropriate equipment. You don't have a helmet on. You don't have gloves on. It's not a safe position for you to be inside that vehicle with the patient as you have the fire crews that are manipulating, bending, tweaking the metal against the path that it wants to go, and you could be injured yourself. Right? Safety of your crew, and then ultimately safety of your patient, kind of in the same instance. Not just the safety of your patient, but if the patient is entrapped in the vehicle, you want to get somebody with the appropriate gear, if able to, inside there to secure them. Cover them with a blanket if you can, if they're needed to break windows. Talk to them to keep them calm. All of these type of things come into play when we're dealing with a motor vehicle accident. And then just understanding the whole time it's a safety concern when you're working alongside of the highway, right? Even when you get the patient out of the vehicle and they're on the gurney and now you're ready to just load them up into the ambulance, it's still very dynamic and potentially dangerous scene. Determine the need for additional personnel or equipment. This goes back to that scene size up, but very important. You show up, you are getting dispatched out with a fire crew. Does that fire crew have extrication equipment? Right? You need to know your local area, because if they don't, then you need to order this stuff early, right? Do you need to get a helicopter, an air ambulance? If you suspect it, order them early. You can always cancel them later on. And then evaluate that mechanism of injury. How much of force was applied to the body and where? Identify any and manage all life threats. We're going to be doing this during the primary assessment. And once you identify a true life threat, it's your job to mitigate that before you move on, right? Now, we can maybe able to delegate this if we have partners or, other people. Let's say we see some major bleeding. You put pressure on that as hard as you can, as now I go through and I evaluate the airway, breathing, and circulation. Shock therapy. We need to treat shock early. Remember, the way that we treat shock is we keep a patient warm, we give them high flow oxygen, no matter what their SpO2 readings are, because they may have some internal bleeding that you're not seeing. And when we use a pulse ox, we're only seeing how much of one hemoglobin is being occupied. And we don't know how much oxygen they're actually getting overall. Spinal immobilization. We need to initiate that early on, prepare for it, get it started, because it does take some time. And then transport immediately to the most appropriate facility. It may not be Banner, right? And it may be another dynamic thing where you don't realize or the extent of the injuries or how critical the patient is until you're already there. And then logistically, does it make most sense to have the helicopter meet you there on scene for you to start transporting to Renown and meet them halfway, or to rendezvous with the helicopter at a smaller hospital like Banner Hospital? They have a helipad there. That way you can kind of, if things start to get worse, you do have backup as far as a hospital there. These are kind of, complex logistical things, just to give you an idea of what goes on with the planning of getting a patient to definitive care, because that is going to be the most important part for trauma, is getting them to the most appropriate facility as fast as possible. Definitive care requires surgical intervention when we talk about trauma. On-scene time should be limited to 10 minutes or less. That's why when we talk about the patient that has test question that goes around and they'll have bilateral femur fractures, and what's the best way to mitigate that issue, package them. Well, if they have bilateral femur fractures, that's multi-systems trauma, and those are significant distracting injuries and one of the strongest bones in your body, so it's going to take a significant mechanism to do that. So they should probably be in C-spine, full C-spine with a backboard, C-collar in place, the head beds and their head taped down, Once you do that, you're essentially splinting those femur fractures. Now we do have the ability to apply a traction splint that could prevent further damage locally to that femur, but it takes time to put on, and essentially that's not going to be what saves their life. It may sound kind of cold-hearted, but nobody ever died from pain, and really pain may be what's keeping their heart rate up and kind of keeping them alive, right? So that's sometimes why we may as far as advanced life support or paramedics may be withholding some pain medication, not because we're sadistic people, that we most likely are, but because we recognize that, right? And there's something that's more important, and it's the overall outcome for that patient. What we do need to do is obtain a sample history and complete secondary assessment, but we don't need to do it on scene. We do that during transport. Essentially, we show up on scene. We're going to do our thorough scene size up, which should be done before we even get to the patient. All right, so we're going to make sure that we have our BSI on, make sure that the scene is safe. A lot of these scenes are going to be dynamic, so the safety should be kind of revolving in your head constantly as things change. Determine the number of patients. Do we need additional resources? What is the mechanism? Because as we look at the patient, we need to have that in our head so we respect it and have a high index of suspicion for especially those internal injuries. And consider C-spine. And if we're doing C-spine, that's going to be probably the most limiting factor on scene. So while you're delegating that out and people are putting the patient in spinal or in full C-spine, we can make sure that we got a clear understanding of the mechanism of injury, that we maybe reevaluated potential for additional resources, or we're at least figuring out what is the most appropriate hospital, and then boom, be on your way. If you don't have the ability to transport because you're on a fire engine non-transporting, you need to have that patient set up for as soon as that ambulance gets there, you're ready to load them up, tell them the story of what happened, describe that mechanism of injury really clearly, give them the sample history, and provide them anything that you got from that secondary assessment if you were able to get that far while you're waiting. So basically, that is your link in the chain, is limiting that on-scene time, and you can still do that even if you don't have the ability to transport. A big kind of thing that I've seen is the issue with crews before we arrive as a transporting ambulance, and they get them on a backboard, but they haven't taken other precautions as far as they haven't removed the clothing and all multi-systems trauma, so we are not sure what essentially the extent of their injuries, and it's difficult to do it at that point once they're already backboarded in. And even if we're removing it just to take the clothes off, it's much more difficult at that point. They haven't evaluated the back before they got them on the backboard. Most likely that's not something that we're going to be able to do en route very safely, especially if we are legitimately concerned about a spinal injury. So always, you may not get to the secondary assessment, but if you're backboarding a patient, we call it, you may have heard it as the old strip and flip. We're going to strip the patient down so that bare skin, so we can see the extent of all the injuries. And when we roll them over on the backboard, we're going to inspect that back. We're going to palpate every vertebrae all the way down to make sure everything's in line, looking for any deformities, any pain on palpation. We're going to do a good circulation, sensation, and motor function on all extremities before and after we get them into C-spine. And then we need to maintain their body heat and try to keep them warm. And most ambulances, fire trucks that I see, they don't keep those backboards in the warm cab with them. They travel on one of those outside compartments. So that may be putting a blanket down on the ground, and then when you remove their clothing, you're going to have to get another blanket on top of them, maybe a chemical warming blanket. Maintain that body heat. Give them high flow oxygen. If they're on a backboard, they're already supine. Make sure that you have that good understanding of the mechanism, damage patterns, anything that you can provide so that when it's time to go, you're ready to go. And consider ALS intercept or air medical transport if you're in a system where BLS is able to transport. It's better to try to get going towards a hospital oftentimes than potentially waiting right there. I've seen this from the side of being on an air ambulance. Oftentimes we'll accept a flight maybe the weather is questionable, and then once we get up in the air we realize, hey, this isn't safe for us, it's not safe for the patient if we get them on board, and we have to abort that mission. And it can leave crews in a really sticky situation if you were waiting on scene there for 30 minutes for this helicopter to arrive and now they're gone. So just ideas to kind of get in your head, because the goal is simple: limit time on scene, get them to that definitive care as quickly as possible. Patient assessment. When a patient has experienced significant mechanism of injury and is in critical condition, we're going to rapidly perform a physical examination, right? It's going to be systematic, and we're not going to leave things out. So when you hear that term rapid, I see this a lot as we start to practice this skill and kind of go over it. Your sense of urgency is different than going through things quickly, right? Because you can't tell, especially if the patient's altered or unconscious, unresponsive, and if you're palpating and moving around, you may not be able to tell that there's a deformity, or that there's, crepitus, kind of bones crunching sound, or something out of the ordinary as you're palpating down the patient if you don't touch every square inch. And again, also as you're doing the head to toe, feeling the scalp, the back of the head, and keep checking your hands for blood, because it'd be a shame if you get all the way down kind of to their midsection and look at your hands and notice there's blood and you don't know where that came from, right? So it's kind of the old saying, slow is pro. Just because you're going rapid doesn't mean that you need to go through it, super fast. You need to do it at a very you need to make sure that you're organized as you're going through and you're not missing anything, so you don't have to do double work. That is what makes you rapid. When a patient has experienced a non-significant mechanism injury, then just focus on that chief complaint. That's that person that stepped off the curb and they heard their ankle pop. So they fell, they hit the ground, they caught themselves. They have no other complaint except their ankle, no loss of consciousness, no distracting injuries. You kind of trust their story, right? They're a good historian. Then there is no need to do that head to toe to examine what's going on. But then again, if that patient is elderly or they have a non-specific complaint, we always can go back to doing that head to toe to figure out, oh, well, they only complained of that ankle pain and they said that they stepped off. You can default an error on the side of being more thorough. But oftentimes, like we stated before, you do this while you're transporting. You do this en route to a hospital, or you do this when there's nothing else to be done on scene while you're awaiting that transporting ambulance, or you do it at the same time that you're performing other interventions to the patient, because you're able to delegate those out. That's why it's so important to be able to stand back and to be able to delegate things so that you and your crew can expedite this process. All right, assessment and injuries to the head. Inherently, these can be very difficult to assess. One, because we can't see what's going on in there. We can't measure that intracranial pressure. And also the patient may be altered. They may be agitated. A lot of things can be going on with a traumatic brain injury that can make that patient difficult to assess, difficult to manage, difficult to maintain control of, and prevent them from causing further injury to themselves. Bleeding or swelling inside the skull is often life-threatening. There's only so much space inside of there. The biggest concern is that intracranial pressure builds up so much that there's not enough space for the brain anymore, and then the brain will start to herniate, right? There is a small hole. We refer to the cranial vault as a cranial vault, but the small hole that goes through the base of the skull, where your spinal cord goes through, attaches to your brain, adheres to it right there. But if we start that herniation and that brain moving towards that hole, or that essentially the base of the skull, the only place for it to go, it's kind of like the octopus that goes through a quarter-sized hole from one fish tank into the other, except the brain doesn't do so well at the other end like the octopus does. So that's going to be our big concern. Just have that inside of your head when you see this signs and symptoms of a brain injury. That's our concern for that intracranial pressure, and that's what's happening, right? Very life-threatening, very significant. We're going to do the neurological examination. We're going to check circulation, sensation, motor function, their orientation to person, place, time, and event. We're going to be looking at their eyes to see what's going on. We're going to be monitoring their vital signs every 5 minutes because they are a high-risk patient, unstable, and looking for those trending, right? The trending for intracranial pressure, the Cushing's triad of the increased blood pressure, the widening of the systolic and the diastolic, the bradycardia, and that Cheyne-Stokes respirations, or the increasing volume with a period of apnea. Some patients will not have obvious signs or symptoms, right? Just like anything else, it's a spectrum, and where we catch them on this. And where this is a problem is they need to get to neurosurgery in order to get that definitive care, right? So it's going to take them a while to get them to that next step, and so we need to try first. Most importantly is to recognize it and getting them, making that decision and that call, and putting those things in line, whether you're transporting them there, getting an air ambulance, somewhere that can get them there as quick as possible, all while you're giving that supportive care and trying to keep them alive, right? When we talk about supportive care, we're talking about supporting their airway, their breathing, their circulation. And when we talk about reassessment on a patient, and if you look at your skill sheet, you should draw a line on reassessment all the way back up to the top, to that general impression, right? Because we're going to go through all those again. A lot of people, it only has 1 point on your skill sheet, reassessment, but that's the majority of our call, and that's probably the most important part when we're with our patient and we're reassessing constantly, right? How are they looking now? How is their mentation now? Are they still alert? Are they still able to talk to me? Or are they getting more confused? Are they maintaining an airway? Are they breathing appropriately? How's their circulation? Right? Are they in shock? Do I need to start treating for shock if I haven't already? Any interventions that I do, has this made things better or worse, right? So reassessment is a lot more than just 1 point on your skill sheet. It's essentially going back and starting from your primary assessment and going all the way back down again. Injuries to the neck and throat. Obviously, there's going to be a concern about the airway problems. We're going to look for DCAP BTLS. So this is a mnemonic that you got to memorize and remember. When I teach my emergency medical responders, I kind of let them off, and this is really what it means, right? When we're looking for DCAP BTLS, is if it doesn't look right or it causes pain, then there's an underlying injury there. But as going now up to EMTs, these words will help you describe this to other medical personnel, and they all have a little bit of a different way of treatment or things surrounding them. So DCAP BTLS, or I always remember it as DCAP BLTs because I like food, but it's deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. All of those are indicative of an underlying injury. And so this will really help you with the blunt trauma to be able to recognize that there's an injury there. Swelling may prevent blood flow to the brain. Penetrating injury may result in an air embolism. So if somebody gets a laceration on their neck and then you start to feel that Rice Krispiness, or you can even hear it with a stethoscope, it's the kind of little bubbly sound that it's making, or it does often sound like if you listen to somebody's lungs like outside of their clothing and it kind of ruffles on their clothing. Except in this instance, it's right against their skin, but that's the sound of an potential air embolism. Right? Crushing injury may cause the cartilages of the upper airway and larynx to fracture. So the strangulation injuries, we're worried about the potential for that airway compromise. And again, if we're thinking that there has been an injury to the structures of that upper airway, it's something that could get worse faster. So this would definitely be, they're controlling their airway fine now and they're talking to me, but this is something that could change. So, thinking of an ALS intercept or a way that we could get an airway established, a patent airway, is going to be our concern. Injuries to the chest. Chest contains heart, lungs, and large blood vessels. So those are a lot of potential for life threats. Broken ribs may hinder breathing. So it may hinder breathing just due to the pain that it causes because of the broken ribs, or if you get that flail chest and you get that paradoxical movement, just kind of the pathophysiology of what's going on may take away and not be able take away the ability of your lungs and your thoracic cavity to cause that pressure differential, so that we're able to get that volume and that ventilation, that air in. The heart may be bruised, so there's blood as it accumulates around that heart, makes it more difficult for the heart to be able to fill up and expel blood, so for the heart to pump, and it kind of squeezes around it. And so as the patient's demands for perfusion increase, the heart is actually less equipped to be able to handle that, to compensate. Large vessels may be torn, and this is a big reason why if a patient goes into cardiac arrest following a trauma, the likelihood that we're going to get them back is very small, because if one of these large blood vessels is torn, you know, we're not, if our ability to maintain that patient until they get to that definitive care of the surgery is gone, right? We're even if in a normal situation, if somebody goes into cardiac arrest, and we're able to keep doing compressions and keep that perfusion going, and we're able to shock the heart and get it perfusing again. In this instance, every time we do a compression, we're also, you know, what we're concerned about when we think about CPR is the heart able to get perfusion. Well, you're able to in the beginning of those compressions, but eventually you're also pushing more blood through this large blood vessel that was torn. So and if it's bleeding out somewhere, it's not returning back to the heart. And so we're going to essentially go through our blood and not be able to get this patient back. A pneumothorax develops again when there's a hole through the lung, or the lung has been penetrated, and now air is leaking into that space outside of the lung but inside that thoracic cavity. And as every breath that they take, or if you're ventilating for them, every time you breathe for them, you're putting more air into that space, and so that affected side of the lung is not going to be able to oxygenate very well. And then as the pressure increases, it'll drop your blood pressure because the heart isn't able to expand as well because of the pressure. Blood isn't able to return to the heart through your venous system as well due to the pressure, and it's going to also start affecting the other side of the lung. So in this instance, they need needle decompression on the affected side, or they will die. This is a obstructive shock that they're in. And then an open chest wound. The problem with an open chest wound is they're not getting that pressure differential. So what we want to do with that is to be able to place a occlusive dressing, which is something that water isn't able to get through, air isn't able to get through, airtight. And then we're going to tape it down on 3 of the 4 sides. The reason why we do 3 of the 4 sides is if the patient exhales, then it's still going to be able to lift up just a corner of that to let some of that air out. And then when they breathe in again, it's going to come tight down onto their chest. It's going to make it airtight, and so that they're able to get that pressure differential, and they'll actually be able to ventilate. Now, if a patient has multiple stab wounds, which we see oftentimes in our demographic, especially at the prison, we don't need to put we need to put an occlusive dressing on all of the wounds in the thoracic region, and don't forget the back either, right? That's where we listen to lung sounds because it's easiest. It's also a direct path to your lungs, and you don't have that the muscular tissue of your chest, so it's kind of a quicker route. We need to have occlusive dressings on all of those locations, but only one of them essentially needs to be taped down on only 3 sides, so that we're able to get that burping when they exhale and let that air through. Injuries to the abdomen. Abdomen contains a lot of vital organs that require a very high amount of blood flow. Solid organs may tear, lacerate, or fracture. And most of the time when you think of solid organs, such as our kidney or liver, that are helping essentially to clean and filter out our blood, they have a very strong blood supply. So the potential for extreme internal hemorrhage is high. And then when we talk about the hollow organs, they could rupture and then they leak out all these toxic chemicals that are fine when and utilized for a lot of body processes when they're locked in that organ. But when they're spilled out into your abdomen, then you could have a whole myriad of problems with all of your organs or your peritoneal space that surrounds your abdomen. The rupture of large blood vessels can cause serious unseen bleeding. Management and transport decision. Scene time. Survival of critically injured trauma patients is time dependent. Less than 10 minutes, right? As quick as possible. So this, you have to kind of go in with a plan or a mode that you work when this is a trauma, right? There's things that you may not get. There's things that you may need to prioritize to do later. And that's the bilateral femur fracture, right? If it was one fracture, isolated femur fracture, nothing else going on there, stable, yeah, it would be more comfortable for the patient, and I'd take my time to apply a traction splint and get them comfortable before transport. But you're talking bilateral femurs or two long bones or any penetrating trauma to the core, blunt trauma, a significant mechanism of injury, which we'll kind of go into a list of them a little bit later. Our priority is their survival, and their survival is dependent that we get them to definitive care, which is trauma surgery, as quick as possible, and the best way to do that is to limit that on-scene time. Type of transport. Ground units staffed by EMTs and paramedics. Air EMS units or critical care transport units, they have a paramedic and a nurse. And this is even more important for us in California based off of the scope of practice and what a ground unit is able to do versus an air unit. Essentially a paramedic on ground versus a paramedic in the air with a nurse. Things that they're able to do as a flight crew, they can do what we call RSI or rapid sequence induction. But essentially what this is to control an airway, we can sedate and paralyze a patient and apply an endotracheal tube and ventilate them on the way to the hospital. And kind of my fear on ground is this traumatic brain injury type of patient, right? Someone was in a motor vehicle accident, they have a significant traumatic brain injury, but they're not unresponsive lying on the ground, allowing you to essentially help them and get them to that definitive care. No, they're walking around, they're not in their right mind, they're combative, they're fighting you. And it makes a difficult situation when we may not have that ability, right, to just be able to push those meds. So understanding what a flight crew could do, it's not just that they have the ability to use a helicopter and utilize that speed, but there are things that they can do that ground units may not be able to do. Destination selection, very important. Level 1 facility provides every aspect of trauma care. Now it gets pretty, in depth, and there's small variations between the different levels, but a level 1, I mean, they have a neurosurgeon on site 24/7 all the time ready to go, right? And then you drop down to a level 2 trauma center, which is what we have close by us as the highest ranked level trauma facility, and they may have to call in that neurosurgeon. So that kind of puts things a little bit into perspective, the difference between these. And then it drops down to level 3. Facility provides assessment, resuscitation, emergency care, and stabilization. And then down to level 4, they just provide essentially ALS, right? So this was the trauma triage scheme that I was kind of talking about before, that there are points that are just essentially based off the mechanism. But most of us go off of the trauma triage criteria set forth by trauma surgeons. and it's standardized, but they all kind of follow the same flow. The first one is just going to be based off physiological factors, right? What's their GCS? If their GCS is less than 14, if their blood pressure is less than 90 systolic, or this has GCS less than 13 on there, then they're going to be required to go to a level 2 trauma center. And then the next step that we kind of go off of is the injury, right? Basically, if they have 2 long bone fractures, any penetrating trauma to the core, a pelvic fracture, a paralysis, then again they're gonna that's a no-brainer. That's where they need to go. And then they'll go down to basically the mechanism. Was this a high-risk fall above 20 feet for an adult, more than 2 to 3 times the height for a children? Was there a ejection or partial ejection? Death in the passenger compartment of the same vehicle? A motorcycle crash of greater than 20 miles per hour because they're not very well protected, then we should be transporting to a trauma center. If not, then we go down kind of the last factor that usually goes with age and also provider impression, things like that. So it's really important that you understand your agency's what trauma criteria that they use, and it's really a great tool because it kind of takes the guesswork out of it for you. And all of them will have in their provider judgment. So if you're not sure, what do you think you should do? You should err on transporting them to the highest level of care possible. Some things that may change that is if you can't handle their airway, right? Then you need to get them in a lower level hospital is much closer. Then you can get them there to stabilize them before you move on. Maybe get them some blood products, be able to establish that airway and keep them alive to get them to that highest level of care. So basically, if you got that concerns like, I don't know if how they are now, if they're going to be able to make it to that level, then you may think about trying to stop off at a critical access hospital such as Banner to get them stabilized for transport to that definitive care. Some special considerations: always remain calm, right? And we say this about all calls, and I know I said it before, that if you do nothing else, you showing up in a sense of calm will calm the patient down, will calm down your colleagues in your team, so that you guys are better equipped and better able to deal with the scene. But I'm glad that it's written on here because you should remember that as you walk up. Okay, I need to remain calm, right? Kind of the same thing with the frightmare face. If somebody has, blew themselves up on a barbecue and they got 2nd and 3rd degree burns on their chest and arms and they're descalped, you are not allowed to look at that patient and essentially freak out and let them see the terror that you see when you look at them, right? You need to remain calm and just get to work and start to think about what goes into next. My complete and organized assessment. It starts out with primary assessment. Any major bleedings? Nope. Move on to airway. Am I concerned about their airway? Any breathing? Do I need to breathe for them? Do they got adequate amount of volume? Are they ventilating okay? Okay, maybe I should just give them supplemental oxygen via non-rebreather because this is a multi-systems trauma or a significantly ill patient. Next, circulation, right? How's their circulation? Anything that I could do I already checked that they don't have any major bleeding, but how is their peripheral pulse, right? Are they perfusing well? Are they in shock? If I haven't already, start treating for shock. High flow oxygen, keeping them warm, position of comfort, and getting this, not I need to go through too quickly, but sense of urgency, right? Correct any life-threatening injuries. The do no harm. Now, when I look at that, I look at it as I'm doing no harm and just trying to help them, right? But I don't want you to see that and be like, oh, I can't do any harm, so I'm scared to act or to do anything. It just means you're kind of, if you're doing everything that you can do to to better the patient's chance of survival, you're not harming them is more how you should see that. Do no harm. It's kind of a, it's a creed that we live by when we're dealing with medicine, but at the same time, don't have it scare you that, oh, I'm going to harm them, right? Because what we're trying to do is we're trying to keep them alive, right? They may not understand how bad these things are, the situation that they're in. They're not a trained professional like you are. So you're looking at the mechanism of injury. You have a high index of suspicion, and that's why I went right for, and I just cut off the chaps and did what I had to do. And I didn't ask for permission because I'm trying to help the patient out, right? You're their advocate. Never hesitate to contact for ALS backup or medical control for guidance. You have help from your base hospital. Ours would be Banner here. You call the Banner ER, you ask to speak with the physician that's on, and then if something falls outside your protocol or you're not sure what to do, they are your contact person for that, right? They supersede, your base hospital can supersede the standing orders that we have through that offline direction and through our protocols. They are our online direction. And also don't hesitate to call the transporting ambulance, right? If you've got some time and they're going there, really fill them in and find out what's going on. It's not unheard of either to, if it's stuff that you don't want to put over the radio or it's, more specific, you can ask for essentially to make a landline, to be able to call them on the phone and get some more information, fill them in on what's going on. All of what you're trying to do is get them to the hospital they need to go to the fastest. That is trauma in a nutshell. We're going to do everything that we can to that they need to keep them alive in this moment and understand what's going on so that we make the best decision to pick a hospital and we're getting on the road, right? And we're moving and getting them to that definitive care.